We're streaming. I'll make sure all the lights are good. Too many lights. Probably be better that way. Too few lights. Yeah, I probably need one more. All right. Welcome everybody to the live stream. I'm going to make sure I'm streaming on the Twitch and also on X and YouTube and Instagram and TikTok. And then we'll get going, folks. We got a lot of content to cover today. Figure we do a night live stream here. So let me make sure I'm streaming okay. Got to get this all set up. Okay, cool. Twitch is looking good. I cancel out of that and trust that that'll go well. YouTube, got to make sure that's looking fine. Both versions. YouTube is going to be pesky. It's going to make me log out again. youtube.com/logout. Got to make sure my vibe coding is looking good over here. Okay, we're building an app. That's all looking good. Let me log into my account and then we'll get started. I made a bunch of notes for everybody today. Cardio. I think we're going to be covering some cardio because we got some requests for that. Oh dear. So while we're waiting, let me ask you a question. A 30-year-old woman has an embolic cerebrovascular accident, and she has some bubbles that are passing from the right to the left atrium in an echocardiogram. What's the diagnosis? That's your question while I'm logging in. While I'm making sure the live stream is going. Okay, so we got some bubbles passing from the right to the left atrium. What is it? What's the diagnosis? Patent foramen ovale. Okay, let me go here. So I made a document for us today. We're going to be going through this doc. So let me just, I'm a ghost, I know. I'm a ghost. Okay. The ghost of Christmas past. There we go. All right, folks. A lot of work today. So here we go. Yes, my website is up. No, I've been signed out. Let me sign in again. And then I'll share access so you guys can see this. There we go. All right, here we go, folks. Is that good? Can you guys see that okay? I'm going to zoom in just a little bit more so it's like very, very easy to see. All right, so does the patent foramen ovale. Allows blood to pass from the right to the left atrium. So I'm going to get a nice photo of this here. And I think the best illustration of this is going to be like patent foramen ovale is probably this photo that I'm going to paste here. Once it loads. Oh, wow. Okay. So there we are. A device that can go through on both sides. That's a decent one. I wonder if there's like a better photo I can use, but kind of gets the point across. Okay. Normally, you don't have to cite if paid for. Situation attribution is required. Shutterstock, use the stock photos to require attribution. You have to do the attribution title by this person using images of Creative Commons license. Okay. I'll make a photo of each of these then. So double bubble with the bubble study presents with deep vein thrombosis and arterial emboli, such as a stroke. Goes right here through the atrial septal, your ASD, septal defect. Basically, there's just a connection on that side. And I have to make sure that there's a Creative Commons license on this. So let me go by tools, usage rights, Creative Commons license. Okay, patent frame and eval. Yeah, this one's good. There's a better photo for you guys. There we go. Okay. Author site license. All right, so there's our first question. Next one. Young man develops a left-sided varicocele after recent surgery. What's the probable cause? All right, we got a compression of the renal vein. Also, hello, Mina. Welcome to the live stream here. Here we go. This is a good one. Nutcracker syndrome. So we're going to be going over that one right now. Okay, and I'm going to get you guys a nice photo of this. There it is. Boom. There's the renal nutcracker syndrome. You have your superior mesenteric artery and the left renal veins. There's some compression action here, the nutcracker effect. And that's when it's compressed between the aorta and the superior mesenteric artery, leading to increased venous pressure. I think I should just have this ready to go up here. And that way I can just make it really easy attribution-wise. Make sure we give credit to these people. All right. And then feel free to ask any questions you guys might have while I'm making this document. This is all part of my effort to make some free materials for you guys on IV Med, which is being launched here soon. Okay, so compression of the left renal vein between the aorta and the superior mesenteric. So there's the superior mesenteric. And the aorta, and we have that compression right here with this left renal vein. It can also cause flank pain and hematuria. And if you guys want to go dive into any of these questions, anybody in the live stream, just let me know and we'll hit on them here. I think the chat should be going, so feel free to ask away. If you need me to zoom into, I can do that. I can do that as well. So now the question is, why would this present with flank pain and hematuria? And I hope it's still going on these streams, by the way. So we'll explain that in a second. I don't know if you guys can hear the rain sounds in the background, but I've got some nice rain sounds going. Feel free to use this time to like lock in yourselves if you don't. If you just want to tune in and out, definitely feel free to do that. We're just going to be grinding though. So yeah, it's still going on Twitch. All right. So the flank pain and the hematuria is due to the elevated pressure and the rupture of the small renal varicosal veins, right? The pressure and the rupturing there. And so we'll do a little practice question here. And I think I'm wondering what the best way to go about doing this is. Like, I don't know if it's best to just do like a practice question, like a quick one. So we have a 22-year-old male presenting with left-sided flank pain. He has no history of chronic stones infection. Exam reveals a left-sided varicocele. Which of the following best explains these symptoms? Answer: compression of the left renal between the superior mesenteric artery and the aorta. All right, so that's nutcracker syndrome there. Left ureter compression by the sigmoid colon. What would this be? That would cause hydronephrosis and colicky pain, non-hematuria from the venous rupture. Oops. Hydronephrosis. There we go. Renal artery occlusions. That would cause renal ischemia, not hematuria. Occlusion of the left renal artery by atherosclerosis. Oops, I put that in the wrong line. My bad. Renal ischemia, not hematuria. Oops, that would actually go. There. Because B is our correct answer. Compression of the left renal between the SMA and the aorta. Renal papillary necrosis. That's going to be seen in an analgesic abuse. Maybe some diabetes, things like that. You have the slough papillae, not varicoceles. All right. So I think that's all there is to say about that one. Squeeze like a nut. Next, elderly man, dysphagia, signs of heart failure, suspected of having cardiac chamber enlargement. Which chamber is enlarged? Answer: left atrium. What's the reason why? Let me get a photo here while we talk about this. Left atrium. And the position of the left atrium in the esophagus in anatomy. So I got to find a good photo for this. This is a good photo. There we go. All right, so this is the relations of the aorta, trachea, esophagus, of heart structures. So let me just note that real quick. By whom? That's the individual there. So our esophagus is this little tube right here. This little tube. Right atrium, left atrium. So enlargement of the left atrium would compress the esophagus, leading to dysphagia. Right atrium, left atrium, compression of the esophagus right here. Left atrial enlargement is often associated with mitral stenosis or regurgitation. On to our next question. These are all the high yield questions from cardio, by the way. Retrograde flow is observed in the left vertebral artery. Which vessel is likely occluded? All right, subclavian stele. Let's get a good image for that one. Maybe we can get like an angiogram of left subclavian stele syndrome. Yeah, this is a good diagram right here. There we go. The author on this, got to make sure we give them credit. Okay. Okay, so we have the arm claudication and vertebral basilar insufficiency. So I'm going to go ahead and maybe we can make a practice question about this one. Subclavian stele syndrome. There's stenosis and occlusion of the proximal subclavian artery, causing the blood to reverse from the contralateral vertebral artery to supply the affected arm. Okay. So the blood is stolen from the contralateral vertebral artery to the basilar. Subclavian stele syndrome. So there's retrograde in the left vertebral. Retrograde flow. So we have proximal stenosis occlusion of the left subclavian artery before the vertebral branch. Lowers the pressure distal to the blockage. So you take the blood from the contralateral artery and it flows the opposite way, steals the blood. Left subclavian supplies the upper limbs. Is there anything else worth mentioning here? Dizziness or syncope on arm exercises, arm claudication, and difference in pressure between the arms. So risk factors as well are kind of important. Risk factors would be like atherosclerosis is the most common. Maybe also you could see like Takayasu, arteritis. That's a large vessel. Arteritis. That's due to the aortic origin of the left subclavian. All right. Cool. Retrograde vertebra on the Doppler. Next, an infant with patent ductus arteriosus is evaluated. Which vessel would be higher compared in the normal infant? I love this question. Patent ductus arteriosus. Oxygenated blood from the aorta flows into the pulmonary artery, increasing oxygen content in the pulmonary artery compared to normal. Yeah. We'll see if we can get a nice little photo of this, because I want to get a photo of the flow. The flow, man. Just go with the flow. Because I am at an all-time flow. Yeah, this is a good photo here. There we go. Get that flow. Young man is stabbed in the chest, the left lower sternal border, fourth intercostal space. Hypotensive, tachycardic. Which cardiac structure is most likely ruptured? Okay. I want to get a photo of the fourth intercostal space. That's what we'll do. I'm going to zoom in a little bit if I can. Yeah, like that. So I want the fourth intercostal space, and I would also love just location of the right ventricle. Yeah, I got a good photo here. So this will be under the... Okay, nice little diagram of your heart here. Superior vena cava. Got our subclavian veins, our subclavian artery here coming out the aorta, subclavian steal syndrome, bouncing back. There's your whole body, the venous and arterial system. Left renal, compression there. SMA. They don't show the superior mesenteric, but crush between that and the aorta. Okay, moving on. Middle-aged man presents with exertional dyspnea, bounding peripheral pulses and head bobbing. Diastolic aortic regurg. This is a good one. I think I want to add this one to the YouTube channel, so I'm going to do that now. And I'm also going to find a photo of aortic regurg. There we go. So the head bobbing, why does that happen? Aortic regurgitation has the wide pulse pressure because of the increased stroke volume and the rapid diastolic runoff. The Moosit sign. So the blood is going back from the aorta to the left ventricle during diastole. So you have increased stroke volume, left ventricular dilation, rapid diastolic fall in arterial pressure. So you have a wide pulse pressure. Alrighty. Next, question 8. But I also want to make sure I do a post. I'm going to do a poll for you guys here. Because I said that I would fix this question. Nice. A woman with progressive dyspnea undergoes cardiac cath. Pulmonary wedge pressure is elevated with normal ventricular pressure. What's the diagnosis? All right, this is mitral stenosis, increased left atrial pressure. You have the elevated pulmonary capillary wedge pressure, and left ventricular pressure is normal. Mitral stenosis, often due to rheumatic fever and the diastolic murmur. All right, so this pulmonary capillary wedge pressure, which is, where to go? Right here. Maybe I could just do some commenting. That's essentially the left atrial pressure. So normally the left atrial and the left ventricle diastolic pressures are almost identical because the blood is just moving freely through that mitral valve, left atrium to left ventricle. But a mitral stenosis, then you have a gradient that widens and the left atrial pressure stays high and the left ventricle is low. So that's the finding there for mitral stenosis. Got to find a good picture of mitral stenosis. Here we go. Yeah, decent. Decent. Could be better. All right. Okay. Try before you buy, bicuspid mitral valve. We'll keep going. On to the next question. So guys, we're building the document. I've already made all these questions together. I just wanted to release this to you guys afterwards. So right now I'm just getting all the photos, all the images that I need for it. Let me check the filters as well on this so that you guys can see me. or you can see the screen a little better. Just give me 1 second. Filter, green screen. Oh, now I'm like super ghosty. Now I'm super ghosty. Jeez. Oh, boy. Oh, brother. Yeah, okay. It's fine. I think I'll just move this out of the way, though. It's not super cumbersome to see. All right. Next. Elderly man, ejection murmur, left ventricle hypertrophy, lightheadedness, chest pain, or exertion, S2 sound is decreased, valve calcification, Tom, aortic stenosis. That's on every single test. Every single test. Every cardio exam will have this. Scooby-Dooby-Doo, where are you? Gotta find a really good photo. I don't want like a super histology kind of view. I'd rather show like a gross pathology of this. Thank you so much. I think that's the first time I've seen the chats. Ifamolu. Like I'm giving a little spell or something. Ifamolu. Thanks. I'm glad you're here. Glad you're enjoying. Hopefully this is not too boring. We're just making some docs, you know. But if you have any questions and comments, you want to like chat about any topic, then just let me know and we'll get off on some tangents and answer some questions about. But right now we're doing calcification, aortic stenosis. I'm just trying to find a nice photo of this that I can put in the doc. Or I might just make my own. I'm just not going to filter by license. And I'll just give attributions, I think. Is that how this works? Yeah, I don't know if this is too grody, but you guys are all med students, so it's all good to go. I'll just add this here. The only thing is aortic stenosis, I feel like you should be able to see all of the... Is that the best? So here is the elderly man, lightheadedness, chest, S2 sound. And we'll go over why this is the case here as well. Now this is good. I like this one. Aortic, calcific. I'll do this one instead. And I'll attribute. All right. That's better. And this is a calcific aortic valve disease. Not just degenerative. This is calcific. And this is by American Heart Association journals. Ooh, subject to copyright, though. It makes you wonder. Oh, you left a comment on MVME 29? Ah, thank you. I guess I just haven't seen the in the live chats. That's awesome. Good. Thank you so much for joining. It's really good to see you. Okay. It says they're copyrighted, so I'm like, I'm asking. I got to figure out what that means. I think it means I can't use it. Got to learn about copyright laws real quick. But yeah, some risk factors here: male gender, oxidative stress, age, smoking, hypertension. Got to know what's completely safe to use in Google image-wise. Like, I don't know, like as a creator, can you just, what can you do? What can you show and not show? Royalty-free, commercially usable, no attribution required, pixels, public domain, all that stuff. Okay, Iqbal says, formula for recalling left ventricle pressure and end diastolic systolic pressure graph. Okay, we'll hit that in a second. I just got to see if I can find some. Okay, so Creative Commons, sometimes credit required or no credit required. Okay, that's good to know. Okay, so I can only use the Creative Commons ones after I view the source page. Okay. Only Creative Commons. I'm just going to give attribution for all of them then. Yeah, that's what I'll do. Okay. Yeah, so let's talk about that. Let me actually just pull up in a new Scooby-Dooby-Doo. Yeah. All right. So let's see here. Diving into this little question. Iqbal is asking about formulas about the left ventricle pressure. Hopefully you can kind of see my screen here. And diastolic. Or rather the end diastolic. And let me know if you have any like specific questions about these guys. And I actually like, do you have any specific, would you like to like draw the graphs and like kind of talk about stenosis? Like, are you talking about all of those, like the graphs like this, and how they expand and how they change? Is that kind of what you want to go over? Like or do you want to talk about the loops and like the isovolumic, volumeric contraction and like the rapid filling stuff, like all those phases? What would be the best to go over? The best way to remember this, in my opinion, like is if it expands out like this, then we have an expansion of the volume. Like typically it's regurgitation, and diastole there's increased filling. But of course, Frank Starling mechanism, where there's filling, there's also output as well. Okay, yeah, sounds good. We can go over that. Faux show. So let's just dive in here. Okay. I have to delete this because it looks like this is not actually, I can't actually use that. Rats. You hate to see it. Okay. All right. Well, maybe we can cover some of the cardiac cycle and some of the pressure volume kind of loop curves. Trying to think of like what the best way to explain this would be. I think maybe just understanding the arrows and the connections. I'm going to pull up a chart as well so I can make sure that I'm saying all of this properly. So just give me 1 second here. All right, so we got our nice little graphs here. Our left ventricle graph typically is on the y-axis, and then over here. So what's happening is we got some pressure, and we got some volume. And so I like to start somewhere consistently, and then work your way around. And stop me if this isn't what you want to go over. But we start with the filling phase, and the filling, we think of this one as like the volume, and this one as the pressure. And so if you're filling, then you're in diastole. So there we go up this way, the diastolic, whoosh. All right, so now we get here, and what is that stopping point, right? That right here is the closure of something. What is the closure of? So something is changing the mitral valve, right? So we fill everything up, and then the mitral valve is like, okay, we're had enough volume. We're good on the volume. Now it's time to close. And so it closes, and then you get the same volume. That's why it stays the same volume, but then it contracts, and then we go all the way up. So now it's isovolumeric contraction phase. So we're contracting, and the pressure is increasing. And then the aortic valve opens. All right, so now our aortic valve is going all up and opening loops. Okay, Iqbal says loops. Sounds good. So hopefully this is what you'd like to talk about here. And then this is the ejection phase right here. So we eject. And now what happens here at our nice little corner here? So this is where our aortic valve closes. Aortic valve is going to close. All right. So as long as we know where these valves are opening and closing, so the aortic valve is going to open here. Whoosh. All right. And now what happens here in this last phase right here, down here, isovolumeric relaxation. Relaxation. All right, because this volume right here isn't changing, and these phases right here, volume isn't changing. And so the easiest way to think about this is if the volume isn't changing, then it's to say the x value is constant for any given y value, then that means you're talking about volume. And volume typically is going to be relating, like if you expand this way, then you are expanding the end diastolic volume. You know, you're just expanding how much of that volume occurs, like especially on that right side. The end of diastole is going to be expanded on that right side. And if you're increasing the pressure, then obviously the y-axis is going to increase, and maybe there's a little bit less filling, and so the volume is going to be scrunched together, right? So just think about it in terms of the end diastolic at the bottom right, and know that that corresponds to how much volume there actually is in the heart. So if it's full of blood, it's all the way over here. And if it's not full of blood, then it's all the way over here. And if there's a lot of pressure, then it's going to be higher. That's why some of the stenosis graphs are high as well. So I should probably show you all of the graphs. So stenosis, and regurg. And the cardiac loops. Because they actually look like little letters here, and I can kind of show you how and why. Let's see here. I'm going to find a really good example, and then I'm going to copy it. Do. Oh, that was a video, not a photo. But I need to find my own non-copyrighted stuff, or I'll just make it. Maybe I should just make it. I just hired somebody the other day to go through and start making some of this stuff, but yeah, maybe like the way that I remember is just what I said about the horizontal. If this increases, then your end diastolic volume is going to increase. So then aortic regurgitation is all the way over here. It just expands, kind of, right? And that's because we have a lot more volume at the end. Because it's coming back in, and so we have more blood in the heart, and that's why it's expanded the volume. So that's the way to think about like aortic regurgitation. And then once you know regurgitation, you can also kind of surmise as well stenosis. So if I press the back button a couple times. So if we have some sort of a change in the heart, like let's say that we have concentric hypertrophy, concentric, you get some hypertrophic changes. Well, the end diastolic is going to be the same, right? The volume is going to be the same regardless. It might be actually a little bit increased sometimes. The end systolic volume is definitely going to be increased as well. And so we have a shift right here and it goes to the right, and I'll draw this in a different color, maybe like green or something, or like this. Kind of like that. And so we're getting narrow, and look at that pressure. The pressure just hikes way, way up. So you subtract the end diastolic and the end systolic volume to get the stroke volume. All right, so that's aortic stenosis. And we already discussed how the normal loop works. And aortic regurgitation we talked about. And then mitral regurgitation is going to be kind of similar. It just looks like a big old blob, except there are a couple of differences. And I would really recommend looking through Melman's arrows for this stuff. And I think he has some pretty good stuff. But basically it just gets really wide on both sides for mitral regurgitation, kind of like this, whoosh, whoosh. And then the last one is mitral stenosis. And so mitral stenosis, I should press the back button a couple times. Mitral stenosis, end diastolic volume, a little bit less. Kind of looks like that. I should have drawn that in a different color. 1 second. There we go. Kind of like that. So we have a decreased end diastolic and also maybe a decreased end systolic as well. And so the stroke volume is down. So it's just everything is decreased here. I gotta find a good photo for this. Hold on 1 second. That has Creative Commons license. It has been a long day, my friends. It's been like an 8-hour day. Let's see here though. I gotta find calcific stenosis. This is a histological slide. I don't know though. Nah. We'll forgo that. I'll leave my admin to do that a little bit later. How about that? But I should put some pressure volume loops here. Pressure loops, volume loops. Yeah, okay. This is good. I found one that I can use. I should just pull this up so I can show you. Here we go. Go to 4. Nice. Or is it? I think it was this one. Yeah, this is the one. All right. So these are the phases that I was talking about. Isovolumetric contraction, and then the relaxation phases, and the aortic valve opening and then closing, and the mitral valve. So the closing and opening of these valves is what causes these heart sounds. And here we have afterload, preload, and the contractility graphs. So as long as you know these 3 graphs, then you can surmise everything else. So our preload has increased. And the easiest way to navigate these graphs is to look at the end diastolic volume on the side where the mitral valve is closing. Mitral valve is closing, that way you know how much there is in the heart in the first place before you pump it out. That's the best way to kind of then work backwards from there. All right, some pressure volume loops. I need to give attribution for this one real quick. Cardiac Cycle by, this is Wikimedia. They're really cooking. This is the Creative Commons. Doodle-doo-doo-doodle-doo-doodle-doo-doo. Yeah, that's probably the best one I'll find. Just know also that the stroke volume is the difference between the end diastolic volume and the end systolic volume. And so the contractility right here, the heart is just pumping harder, right? So it's squeezing more blood out for each beat. And so you have an increased stroke volume and increased ejection fraction, and the end systolic volume is going to be decreased. And that's why this goes to the left. So the best way to navigate end diastolic volume over here and systolic volume over here, and then you subtract them to get the stroke volume in between, which is still going to be greater even though this thing was shifted to the left, right? End systolic volume, you're squeezing it out of your heart. This guy right here, our preload. So here the heart is being filled with more blood, and so we have this EDV is greater, right? This is like you're stretching a balloon. And so because of the Starling mechanism I was talking about earlier, that means the stroke volume is increased. That's Starling's law. And so the loop is just shifting to the right. That's the increased preload loop, right? And then contractility, you squeeze more out of it. And so at the end of systole, you're left with less inside of it, right? Now, afterload, that's where the heart has to pump against a high pressure. It's like you're squeezing into a really tight hose. And so this is hard to eject the blood. And so you have decreased stroke volume, or rather, sorry, yeah, you'd actually have some increased stroke volume. But if it's harder to eject the blood, then you have decreased stroke volume. So for afterload, the big thing here is end systolic volume is going to be dramatically increased. There's more blood that's left behind at the end because you're just pushing against something that's really hard to go through. And so that's why this is going to be really tall and narrow. Why is this stroke volume elevated? I feel like the stroke volume here, this is wrong. I feel like this is wrong, right? Or am I tripping? This has to be wrong because, yeah, because the end systolic volume is elevated and the stroke volume is end diastolic volume minus the end systolic volume. And so this surely is wrong. So I actually have to edit that. So let me go to draw symbols. Yeah. How do I draw an arrow on this? You know what? I'm just going to yoink. How about that? How about that? Yeah. You know, it's because like the stroke volume is less because there's less blood that's pumped out, you know? So like, that's just wrong. Like, I don't know what to tell you. So I'm going to crop that one out and now it's gone. That's why I got to make my own graphs because I don't trust these people out here. I don't trust Wikipedia. I don't trust you, Wikipedia. So yeah, hopefully that makes sense. Hopefully it didn't confuse you there with that little thing. Because I was like confused for a second there. I was like, wait, why are they saying the stroke volume is increased if the end systolic volume is increased? Because here, this is the formula. Alrighty. Cool. Oh, and this doesn't even pertain to the question at hand. So I have to actually pop this up. Yeah, it kind of does. Stenosis is fine. All right, a woman is hospitalized due to infective endocarditis. Cardiac auscultation, there's a mid-systolic click. Mitral valve prolapse, the clickety-clickety. I feel like that's from something. Is that from a movie? Clickety-clickety. I feel like it is. I don't know why. All right, let's see here. Infective endocarditis. All right. So this is like just a super buzzy question. Typically there's that regurgitant murmur that comes after that clicking sound. Yeah, that's pretty much all there is to say. This is really just a memorization question. Mitral valve prolapse. And you have that mixed mattis degeneration of the valve leading to the mesosystolic click. Let me just highlight the important words here. Common predisposing factor for infective endocarditis. And so in mitral valve prolapse, the mitral leaflets, they balloon back into the left atrium during systole. And so that creates this abnormal, just this jet of blood, which is the mitral regurgitation. And that bunch of blood hits the atrial endocardium and the valve surface, and you get this repeated mechanical stress going on. And so the surface is then damaged, then exposes the collagen, and you get the formation of a thrombus, and it's a whole thing. So mixed mattis degeneration, the weakened, then the floppy leaflets. Alrighty. I don't think I need a photo for this one. I'm trying to think. Infective endocarditis? Probably not. Yeah. All right. Well, what else is there to say about this one? The IV drug pattern stuff. You can talk about tricuspid valve endocarditis. So if you have like this left-sided endocarditis, like mitral valve prolapse, it's not going to be about the IVU stuff. That's the tricuspid stuff. So right-sided, mostly IV stuff. Left-sided is abnormal valve stuff. So rheumatic diseases, bicuspid, aortic valve, prosthetic valves, all that stuff. And the left valves are under a lot of high pressure, so there's more turbulence there, and it makes them more prone to colonization. If there's already like some structural abnormality, it just kind of builds on itself. Okay. Ischemic heart disease and complications. An old man with inferior wall ischemia or myocardial perfusion scan. Which coronary artery is blocked? The inferior. Yeah, these ones you just kind of have to memorize all the zones of the heart, which makes me want to sing the Finding Nemo song. Let's name the zones, the zones, the zones. Let's name the zones of the open sea. Old man, inferior wall. So it's the right coronary artery. And there's got to be a really good graph that I can show, maybe with the leads and like where they pertain. But inferior, and this is in the right dominant crowd. Probably inferior wall ischemia, we're assuming right dominancy. So the inferior wall of the left ventricle is the diaphragmatic surface of the heart. And so that is supplied by the posterior descending artery. And in 80% of the right dominant people, the posterior descending artery comes from the right coronary artery. But in 10%, it comes from the left circumflex. And they like to sometimes ask about that. Right coronary artery also supplies the SA and the AV nodes, which can lead to bradycardia and inferior myocardial infarctions. I wonder if I have a photo of this, if I could find one. Gotta find a good photo. Yeah, yeah, yeah. Is the latency on the stream okay? Like, is the quality? I'm gonna get better internet tomorrow, so I can start to do better streams. But I'm wondering, like, is it really? Is it slow? I'm curious. Okay, right coronary artery. Where's our PDA? Posterior descending. Branching off of that in the vast majority of folk. And SAAV nodes. And then here's our left coronary artery and our right coronary artery. So inferior myocardial infarction, right coronary artery, bradycardia, AV block. That's what there's to know. So this is the coronary arteries. Alrighty. A patient with irregular rhythm. We all know what that is. Left atrial appendage. Irregularly irregular. Atrial fibrillation. Give an example of AFib here real quick. There we go. Irregularly irregular. You just can't predict it. Long-term anticoagulation prevents the stroke in patients with AFib. In AFib, left atrial appendage is the common site for thrombus and embolizes and produces a stroke. All right, got to give them on the long-term anticoagulation. 65-year-old man, exertional chest pain. ECG and enzymes are normal. What's the next step? He has the pain on exertion. So I got to highlight exertional. Then everything is highlighted. So when everyone's super, nobody will be. Stable. Exercise stress induces stable angina. We can also do a test with dobutamine and dipyridamole. Patient died following an MI. Biopsy of myocardium shows neutrophils and infarcted myocardial tissue. What's the timeline post-MI? Okay, I feel like I made a video on this not too long ago. Neutrophils. The timelines. Yeah, we got to go over the timelines real quick. So let me scroll down. All right, so I think I should probably for this one just make like a chart. So we'll do like an insert table, and I guess they split it up into like 5 different spots. Yeah, like 5 spots, and then how many do I need? Probably 2 months. We'll just do the time and then the symptoms are probably like this. That's probably good enough. So first one is going to be, type this up, like 0 to 24 hours. So like within 1 day. And in the first day, this is early coagulative necrosis. So early coagulative necrosis. And I should probably do bullet points here. Ooh, gross. Maybe I should just do this. Ooh, gross too. Just my own. That's fine. You have the wavy fibers. You also get the bands from the calcium influx. And then neutrophils just start to show up. Just barely start to show up. And then the risk factor there, I should add like another column as well. Insert 1 row below. And this is going to be like the risk factors. So the risk would be, you have like the arrhythmias for a risk factor, cardiogenic shock. Oops. Okay. And then next, after our first day, 1 to 3 days, which is what this patient was dealing with your neutrophils that are infected, here you have heavy neutrophil inflammation. And I don't want to do that. Heavy neutrophil. And that's just because there's a lot of acute inflammation happening. You got some yellow pallor on it. And the risk is fibrinous pericarditis. Alrighty. Next, put the timeline on that. 3 days later, 3 to 7 days later, you have the macrophages join the party. Macrophages come in and they eat the debris, and then the tissue starts to soften. There we go. Oh, there we go. And I guess the risk factor here would be some sort of a rupture, because that would be bad. Then 1 to 2 weeks later, So these 1 to 2 weeks, you have the granulation tissue, the fibroblast, the collagen, the new vessels, and it'll be pink as well. I should put that little guy there. And here as well. Pink. It also looks kind of soft on the gross examination. Risk factor. Ventricular aneurysm. Okay. Then after 2 weeks, then maybe even months later, what are we dealing with here? Well, for starters, you're going to have this dense collagen. That's the biggest thing they'll always ask about that. But it's going to be white and firm grossly as well. And there you have a risk of Dressler syndrome. Also chronic heart failure. Okay, there we go. We did it. That wasn't too bad. So the timeline, we have the descriptions, and we also have the risk factors. Okay. Acute inflammation. Neutrophilic inflammation of the heart. I wonder if I can get some neutrophils through my Creative Commons license here. Sorry if I'm more distracted than normal on this live stream. I'm just trying to get this document ready and prepared so that I can put it out for all of you guys here soon. But you're seeing live going through the process. Okay. Looks like I can't find one very easily. I guess, yeah, these are neutrophils. I could do this. Here. I'm going to pop this in here. Boom. Boom, shika-boom. How about that? Myocardial infiltration. Wikimedia Commons coming in clutch. Nice. Okay. Cool, guys. Cool. So we got some neutrophils, myocardial infarction, days 1 to 3. So these neutrophils are these like little purpley guys. I'm also color deficient. I don't know if you guys knew that, but it makes it. I don't think I could ever be a histologist because I have some color deficiency with red and green. Nothing too bad. But here, oh, this is an even better photo. Look, they even tell you that these are the neutrophils. Oh yeah, look at that. Ho ho ho. Does it get much better than that, folks? Does it? I don't think so. So this is histopathology. That's just like some neutrophil and infiltration, even though this is neuron. Wikimedia. Cool. Cool beans. And also I want to show this histopathology as well. I think this is important. I think this one's important too. So now we're cooking, folks. Now we're cooking. Histopathology of myocardial infarction. I think this is actually the best one. Nice. Looks like we made it. Okay. All right. Moving on. So Mobitz 1 AV block, we mentioned this before. The right coronary artery and right dominant folk controls the AV node there. So that's going to be the right coronary artery for the AV node here. So Mobitz type AV block, and I got to find a photo for that. But then, and I'll be giving this to all of you guys here soon. Reduce myocardial oxygen demand is the goal of treatment for stable angina. Reducing the heart rate, contractility, and the wall stress. Beta blockers, nitrates, and calcium. So balancing that oxygen supply. Next, arrhythmias. An old man has interior myocardial infarction but rejects revascularization. Then he becomes hypotensive and a new onset harsh holosystolic murmur. What is the diagnosis? What's the diagnosis? All right. So we have a rupture of our interventricular septum 3 to 7 days post-MI. And if we look at our handy dandy sheet that we just made up here, 3 to 7 days, we're looking at macrophages and the tissue starts to soften with a myocardial rupture. We have a myocardial rupture right here. So we have that rupture that occurs, leads to a harsh holosystolic murmur and cardiogenic shock. And that, my friends, that is an emergency. I don't know what I would put for the photo here, but basically, you have an old man and he's got a myocardial infarction. And this is actually the LAD territory that I'm realizing because we have an anterior myocardial infarction. So LAD territory, and there's no revascularization there. And so it's like day 5, hypotension and a holosystolic murmur. What's happened is there's a regurgitant or maybe a shunt lesion. And that sudden shock means that something acute has happened. So maybe a differential here that you could give, a couple of things. You could say, 1, maybe this is papillary muscle rupture. You could say this is a free wall rupture. So it could be like an acute severe mitral regurgitation, but this is probably more common in the inferior. The inferior leads, the inferior myocardial infarction, like the right coronary artery. Free wall rupture would have tamponade, and that would not be a murmur. So it's just differential diagnosis right here. Tamponade, not a murmur. And by the way, if you guys have any questions that you want to cover on this, just let me know, and we can slow things down. I've just been a little bit kind of like distracted because I'm finding images as well, but I'll do my best to answer any questions. Could also be an interventricular septal rupture. All right. That would create a VSD with a left to right shunt. And so if there's a VSD with a left to right shunt, you have a loud, harsh, holosystolic murmur, and that could also be seen with your hypo or your cardiogenic shock. So the anterior, the LAD lead, right? LAD tells us it's a septal rupture. And then the inferior RCA would be a papillary rupture. So I'll write that down, RCA. And the inferior is the papillary. And then any myocardial infarction could be a free wall rupture. So I'll just say like any myocardial infarction here. But this is an interventricular septum rupture. All right. And why? Because they tell us there's a holosystolic murmur that happens. And this is like classic VSD with your left to right shunt. Know what I'm saying? Know what I'm feeling? Know what I'm saying? Whoa, I just opened Twitch. Hey, everybody on Twitch. How you guys doing? We're on YouTube, and we're also on Twitch, and we're also on X, and there are a bunch of people saying hi. I got to loop you guys all in together so you guys can see the chats, right? Otherwise, it's just like me talking into the voids. But good to see all of you guys. Hopefully you guys are doing well. Thank you for joining. We're covering some high-yield topics. I made this document where we're covering high-yield cardio topics. And then I'm going to be releasing this to you guys soon because I promise whenever we get to 1,250 subscribers, I'm going to release a question bank and also a medical library. And this is part of the 7-day prep plan, right? So I'm making this high-yield document for you guys. All right. Left ventricular hypokinesia undergoes CABG. Follow-up shows improved ejection fraction. Okay. What explains this recovery? Hibernating myocardium. This is the chronically ischemic but viable myocardial tissue that recovers function after revascularization. So what the heck is going on? Basically, what even is hypokinesia? Well, that's weakened contraction, right? So you're not contracting as much as you should. And this right here, this is just revascularization. Anytime you see that, revascularization. And the ejection fraction is now much better. So what on earth is happening? Well, if we have chronic ischemia, then the heart muscle can go dormant, right? It's just like, I'm done. I'm hibernating. I quit. And it saves energy. That is a hibernating myocardium. All right. So present in a chronic ischemia. It's like bears, I guess, that apparently do that. Well, I heard that they don't hibernate for the winter. So I'm like, I don't even know what to believe anymore. But they certainly slow their heart rate. And similarly in our heart, if we don't have that yummy, yummy oxygen, then we have to hibernate our myocardium, right? And so once this blood supply is restored, then the function recovers, right? So the stunned myocardium is acute ischemia. Hibernating myocardium is chronic ischemia. And I should probably write that out because they might ask about that. So stunned myocardium is acute ischemia. That's like after like a reperfusion of a myocardial infarction, something like that. And you have like that transient dysfunction, even though you restore that blood flow and it recovers in like hours or so. I'm gonna put my iPad here to the side. So there's a hibernating myocardium, hibernating, chronic, stunned, acute. All right, next. A 32-year-old woman with chest pain and ST elevations. Gotta like pop my neck. Angiography is normal, but acetylcholine reproduces the symptoms. What is the underlying mechanism here? Underlying mechanism. Chest pain, ST elevations. What's going on? Let's see here. So we have smooth muscle hyperactivity, vasospastic angina. Hyperreactivity of the coronary artery, smooth muscle leading to transient ischemia. Transient ischemia. Okay. So what does it mean that the angiography is normal? I should just I wonder if I could just comment this and have you guys just comment on this document if you want. And we can kind of build this as a community doc together. Oh, what if I embedded this into my website and then we could all edit it together? Is that wild? Yeah, that's pretty wild. Maybe not. I think I'll put it on the website in some capacity and share the comments here. I'm still deciding, not sure. But angiography being normal, what does that mean? No fixed plaque. And you can't see, but I'm making a comment here. There's no fixed plaque. All right. Okay. So we give acetylcholine that reproduces the symptoms. And what's the mechanism? So ST elevation with normal coronaries, that rules out obstructive CAD, coronary artery disease. So we don't have obstructive. That's nice to know. And acetylcholine triggers the vasoconstriction in these kind of susceptible patients. That means that it's a vasospastic angina. This is Prinzmetal angina. And so the mechanism is just the coronary smooth muscle hyperactivity causing the transient spasms, and then the ischemia, and then the chest pain, and the ST elevation. All right, so that's what's happening. That's our mechanism. That's what's going on. Vasospastic angina caused by hyperactivity of the coronary artery smooth muscle, often treated with calcium blockers and nitrates. Calcium blockers and nitrates. There's a really good sketchy on this one. But yeah, it's the tightening suddenly, right? Even though they're nice, clean vessels, right? They're beautiful, clean vessels, but they're tightening. And that is vasospastic angina, Prinzmetal. And so it's overactive smooth muscle of the arterial wall. It's not from plaque. Plaque is the typical cause of myocardial infarctions. And it's a sudden spasm, so it stops the blood briefly, and you have chest pain and ST elevations, and you treat it with calcium blockers and nitrates in the artery. Okay. So that's how that works. An old man develops sharp chest pain, worse than inspiration 2 days after a STEMI, and he has the pericardial friction rub. What's the diagnosis? Fibrinous pericarditis, the friction rub. All right, typically resolving anti-inflammatory treatment. High-dose aspirin is used to manage these pain. High dose of aspirin. Why do we give aspirin to these patients, and what is this mechanism? And let me see. Are we still streaming? Is everything okay? I wonder, how is the quality? Is it latent? But yeah, so basically we got this dude, and he's an old man. 2 days after he has his STEMI, he has chest pain, all that stuff, and he has a friction rub. Basically, after you have a myocardial infarction, the dead heart muscle will trigger inflammation in the pericardium. And so that causes fibrinous pericarditis, which is a layer of the fibrin. And this is 1 to 3 days after myocardial infarction, which would show up with a lot of neutrophils as well. So early, 2 to 3 days, fibrinous pericarditis, and then later you have the Dressler stuff. And that's like the autoimmune stuff. But this is just fibrinous pericarditis through inflammation post-myocardial infarction. Give them some anti-inflammatories. All right, next. A 58-year-old man, inferior STEMI, becomes dizzy and bradycardic. Blood pressure is 70/40. What's the next step? What are we going to give this guy? We're going to give him a beta blocker. No, we're not. That would exacerbate the hypertension. Don't give him nitroglycerin either. Right? That'd be insane. So, dizzy, hypotensive. Why does this happen? Why is this the case? Well, this is right coronary artery that supplies, we mentioned this before, RCA supplies the SA node and the AV node. And so an inferior myocardial infarction involving the RCA in 80% of the people is going to increase the vagal tone. And then that causes bradycardia and low blood pressure. All right. And so the first line drug is going to be atropine. There it is. Boom. Because you're blocking that vagal tone. You're blocking the vagal tone. The heart rate goes up. The blood pressure improves. And if atropine fails, then, well, you might need to do some pacing. But yeah, give him atropine. That's the answer. Next, a man with intermittent palpitations has AFib on ECG. Where is the likely source of aberrant electrical activity? Okay. AFib, ectopic foci. And so you do ablation in the foci as a treatment for atrial fibrillation. That's the answer to this question. Let me just make sure the stream is going good here. All right. So yes, it's the ectopic foci. That's what causes this. And catheter ablation in AFib targets, could target like the pulmonary veins. I'm trying to think of like what a good practice question would be. So let's make a practice question that I'll paste right here. And I think I'll do it in like code notes. Wouldn't that be cool? Building blocks. How about that? No. What should I do this in? A chart, horizontal lines, break, a line break, page element. Ooh. I don't know if there's like a code or something. I'll just try this. Why not? Just trying something different. Practice question. Oh no. Is the stream wigging out? Can you guys hardly even see the stream? Oh no. I hope that the stream is okay. Maybe my computer can't quite handle it. Here, let me test. I'm testing. I'm waving around. Hopefully you guys can see this. Oh man. I promise I'm not moving in like 8-bit motion. I don't know why this is happening. But don't worry. Friday I'll have this all figured out. I'll have it all figured out. All right. So practice question here that I'm going to share. We have a 65-year-old woman. I'm going to post it right here. Absent P waves. We know this is atrial fibrillation. Which anatomical structure is targeted during this procedure? All right. So our answer is B, the pulmonary veins. The most common site of ectopic electrical foci that trigger AFib. Alrighty. Moving on. And I apologize if this isn't working still. I don't know why. I really wanted this to work today. We'll have to just speed through these then so that I can log off and try to figure this out. But a man with palpitations and atrial flutter, what's the source of the aberrant? A flutter reentrant circuit. That's the reentrant circuit stuff. Ablation can treat it. Next, a child with bilateral sensory neural hearing loss has a prolonged QT. It's the potassium channels, Dravel-Lange-Nielsen syndrome. Mutations in the potassium channels, prolonged QT, and hearing loss. All right, athlete following low resting heart rate, progressive PR interval, and he's got the dropped QR complexes. Which of the following is the best step in management? All right, reassurance, this is just Mobitz type 1, common in athletes because of the increased vagal tone. All right, next, 76-year-old woman with AFib, confusion, yellow vision. She's definitely got digoxin toxicity. Easy question. Very easy. Next, patient is about to start long-term amiodarone. Amiodarone. I've heard people say amiodarone, but I always say amiodarone, but I'm trying to change the way they say that. Amiodarone. Which test should be done before starting this therapy? Always, every single time, TSH and the PTH. I was listening to like a podcast the other day. I was talking about this, but amiodarone affects the thyroid and the parathyroid function. And so you have to assess that first. You got to try. You got to see what's going on before you administer that. A 56-year-old man with AFib starts dovatilide. Which arrhythmia is most at risk for? Polymorphic ventricular tachycardia. All right, prolongs the QT. There's a really good sketchy on this one, on all the antiarrhythmics. Close monitoring of the QT is necessary when you're on this drug. Continuous machine-like murmur. Which drug will treat this? NSAIDs. Endomethacin inhibits the prostaglandin and promotes the closure. But you don't want to promote the closure if that's the only way that they can breathe and get the blood going to the lungs. So if they have some horrible anomaly, then don't give them NSAIDs. In fact, you have to keep it open. You don't want to inhibit those cyclooxygenases. We do not want to close those pad ductus arteriosus if they have like some huge malformation. What dynamic changes occur in the neonate after birth? Pad foramen valve closes and the ductus arterius closes as well. That always happens. Happened to you, happened to me, happens to everybody. All right. Next, a newborn with cyanosis. Known tetralogy of flow requires immediate stabilization, which intervention is indicated. Maintenance of the ductus arterius patency. That's what I was talking about earlier. The prostaglandin E1 infusion can improve oxygenation by allowing it to bypass. Prostaglandin E1, that's the answer. Infant with a resting heart rate of 55. Holosystolic has both of them. Which genetic condition does he have? Down syndrome. Why? Why? Because of these endocardial cushion defects that are found in those with Down syndrome. A child with tetralogy of flow squats. What is the physical mechanism? Increased systemic vascular resistance. That's what squatting does. Compensatory to alleviate hypoxic spells. Alrighty, the squatting increasing. I think I should, I'll find a photo afterwards. I won't burden you guys with doing that because I feel like I was looking up too many images earlier on in the stream and I want to keep this like high yield for you guys. So I apologize for earlier in the stream. I was really looking up a lot of photos, trying to like drag them over and do like 3 things at once. But I think it's just better if we just cruise through these questions together. A 20-month-old boy, this is Cartageners because of that ciliary dyskinesia, sinusitis. They could even say that he has like backwards body innards. But this is just recurrent pneumonia, sinusitis, and displaced heart signs. Yeah, toward the right. So they switch it around. Cetus inversus, respiratory infections, and sinusitis due to the defective ciliary function. Next, cardiomyopathy. A young man in exertional syncope has a asymmetric septal hypertrophy. What structures cause a left ventricular obstruction? Left ventricular obstruction, exertional syncope. Okay, so he has some hypertrophic cardiomyopathy, and the mitral valve leaflet is hypertrophied. And so we have the syncope because of that obstruction of the left ventricular flow. So we got to use some beta blockers and calcium channels. Next, elderly man, dyspnea, jugular vein extension. He's got left ventricular hypertrophy and echo. Biopsy shows pink deposition. What is the diagnosis? Amyloidosis. We love our pink, right? Senile amyloidosis. Alrighty. And we have to know the restrictive and non-restrictive cardiomyopathies. Those are important in high yield, so maybe we can go over those in a second. All right, so elderly man, dyspnea, JVD, edema, left ventricular hypertrophy, and he's got that Congo red, apple green bifurengence, the pink deposition stuff, amyloidosis stuff. So the pink deposition in the myocardium is obviously amyloidosis, and then the elderly is going to be senile systemic amyloidosis, senile. And that's due to the TTR misfolding and the deposition in the myocardium, and so you get restrictive cardiomyopathy with the stiff ventricle. And the stiff ventricle and impaired filling, and then you have that picture with like the JVD and the edema and the dyspnea, and it's no fun for anybody involved. Next, young man collapses. S4 is hypertrophic cardiomyopathy. I think I've said that like a billion times. Yes, it's hypertrophy of the S4. Yes, because that S4 sound is when it's going just hitting the wall like crazy, like just an insane little drop of blood hitting that wall because it's so hypertrophied. Next, a 35-year-old, and he's got a big old leg swelling and all this stuff. S3 is systolic heart failure. So dilated cardiomyopathy is S3, following viral myocarditis. Alrighty, early intervention needed for that one. Improve outcomes of viral myocarditis. A young man, sharp pain, mild upper respiratory symptoms, and ECG has diffuse ST elevations without reciprocal changes. What's going on? Viral pericarditis. So treatments use NSAID and also colchicine for the relief. Why do we use these things? Anybody know? Also, hopefully, can you guys see what I'm doing? I really worry that like the stream, here, let me test this out. I'm going to see if how big the latency is and if you guys can even. Oh dear, this is like a 10-second latency. Don't worry, guys. I'm about to get some really nice like hardware from like Best Buy this next week. And I'm waving my hands until I can see myself waving my hands on my own screen. And that tells you how much latency. Okay, now I've stopped. Like, that is how much latency that you guys are experiencing. And I apologize for that, but don't worry. In the future, we're going to get this right. So yes, we have this dude. And so what's happening with viral pericarditis? Okay. Well, Coxsackie, like influenza adenovirus, that can inflame the pericardium. And so you inflame it, causes like the chest pain, the friction around, the diffuse elevation, all that good stuff. So NSAIDs and colchicine is what you get for this condition. What else is there to say about this? I guess like why NSAIDs? And high dose aspirin. Well, they block the prostaglandin synthesis and they reduce that inflammation. And then that provides like just pain relief, right? Because of all that inflammation, the pleuritic, chest pain, the first line choice for acute pericarditis, and the colchicine, right? That inhibits the microtubule polymerization. It stops the white blood cell migration and the inflammatory signaling. And so you're reducing the recurrence of pericarditis, and that's like its biggest role in colchicine. So it's used together to shorten the symptoms and prevent relapse. 32-year-old woman, worsening stuff. TSH is 0.1. What do we got? Okay, high cardiac output. Probably because we have hyperthyroidism, and so it causes increased output. So 70-year-old man, EF of 30%, which diuretic improves survival. Spironolactone, it's a saver. It'll save you, improve survival for heart failure with reduced fraction by reducing the cardiac remodeling, spironolactone, and also monitor for hyperkalemia as a side effect. Too much of that potassium, and we can talk about the mechanism in a second after we do our hypertension, which is a 65-year-old woman. Treatment for hypertension develops bilateral leg swelling. And labs are normal, which medication was likely prescribed. Okay, and I'm going to zoom in here. Oh, I can't zoom in. Whatever. Amlodipine side effect. It causes peripheral edema, right? So you add an ACE inhibitor to mitigate those side effects. And I mentioned before spironolactone, the mechanism and how it helps with heart failure. You block it with spironolactone. So that decreases the fibrosis, decreases the remodeling, and improves the survival, not just the symptoms, right? So hyperkalemia, too much potassium. And why? Because aldosterone normally increases the potassium excretion. And so you have to monitor that with spironolactone. Yep. Cool beans, y'all. Cool boons. Cool boons. An old man with a myocardial infarction receives medication in the ED and develops sudden wheezing and shortness of breath. What is the most likely cause? Beta blocker induced bronchospasm. So non-selective beta blockers cause bronchospasms by blocking beta 2 adrenergic receptors in the lungs. And that's just what they do. That's their thing. Cardioselective beta blockers are referred with if you have a respiratory condition. Cardioselective. Next, a 59-year-old man is starting lisinopril. Compared to the therapy, what changes are expected on lisinopril? Okay, so this one, everything up to this point is going to be elevated, and then these things are going to be down, but bradykinin is going to be up, though, because it's not going to be broken down. And that's what causes the cough, is the bradykinin. That's what causes the cough, my guys, my dudes, my dudettes. Let's see here. I have to undo that and make this bigger so we can all see the screen now. An old man is receiving an ACE inhibitor for hypertension, switches to an ARB. What changes in all of this stuff are you going to see with the ARB stuff? So ARBs block angiotensin 2. And so we're going to go renin up, angiotensin 2 down, aldosterone down, bradykinin no significant change. Alrighty. Bradykinin changes with those ACE inhibitors, as we mentioned before. ACE inhibitors, ACE can't break it down, so the bradykinin is elevated, and that causes a persistent cough. Okay, man with pulsatile abdominal mass, smoking the AAA, right? More common in males, there's a family history. Young man has a severe headache, vomiting, all this stuff. Which vascular abnormality is most likely associated? Coarctation of the aorta. All right, coarctation, different blood pressures in the upper and lower extremities. A man with progressive fatigue, ACDs, bilateral leg swelling. Which lab confirms the diagnosis? Increased or elevated urinary 5 high, right? Carcinoid syndrome. Carson, you say hi to your friend Carson 5 times. Hi, Carson. Hi, Carson. Hi, Carson. Hi, Carson. Hi, Carson. Hi, Carson. That's how that's just how you remember it. Carcinoid. Hi, Carson. I don't know. Easy to remember after that. We're almost finished, guys. Almost finished. Hypertension patient, tearing chest pain. BP significantly different between the upper extremities. We kind of talked about this. Intimal tearing, right? Aortic dissection. They're different. It causes differential blood pressure in the readings between the limbs and disrupted the blood flow. A man in a motorcycle accident, trauma, hypotension, distended neck veins, and clear sounds. What is the diagnosis? Cardiac tamponade. Fluid is accumulating here. And so you have decreased cardiac output because of that displacement, and you have the distended neck veins as well. Pulsus paradoxus as well as seen in cardiac tamponade. Okay. Autonomic. Syncope when buttoning his collar. Glossopharyngeal is the nerve responsible for this reflex. So this is the carotid sinus hypersensitivity, and it's our carotid sinus reflex. So syncope due to that vagal stimulation. All right, next we have a rise in JVP during inspiration. It's constrictive pericarditis. So it's going to be poor radiation, cardiac surgery, and tuberculosis. So this is going to be a fibrotic change and also the Kussmaul signs, okay? So this one, I've made a couple of videos about this. We'll talk about this in a second, but a woman has severe bleeding and trauma, presents with hypotension, tachycardia, which is expected in cardiac contractility, baroreceptor firing, and also ANP release. Okay, so she's got the bleeding, so hypotension, tachycardia. So the contractility is going to increase. It's not going to be firing as much, and the peptide is not going to be released as much. But because of that, we have more contractility. And so when you have hypotension, the systemic activation increases, but you also have that decreased baroreceptor firing, and that's what kind of causes the sympathetic activation. And ANP release is also decreased because you have less blood volume. Next, an elderly patient, septic shock, receives norepinephrine for hypotension. What is the intracellular response in cardiac muscles? Increase that camp. Norepinephrine stimulates it, and you got to increase that camp. It's a good key secondary messenger for the adrenergic signaling pathways. Next, we have a 50-year-old. And wow, this goes on forever. This is the last page, though. Last 3 questions. 50-year-old septic shock. What are the measurements? Okay, so we have septic shock. That's the one that's kind of paradoxical, in my opinion. Here you have an increased cardiac index, but the decreased left atrial pressure and also the left, or rather the systemic vascular resistance is decreased. All right, so early recognition management, you got to improve the actual infection, what's causing that septic shock. Next, 62-year-old man, cardiac cath, presents with painful mottled skin on his feet, acute kidney injury, and eosinophilia. What's the diagnosis? Cholesterol crystals, right? So they dislodge during vascular procedures, leading to occlusion of small vessels and systemic inflammatory response. Alrighty. And we'll talk about this one too, but I did want to mention, I said I was going to talk a little bit about constricted pericarditis and Kussmaul signs. So basically, you have radiation that causes the fibrosis and the calcification of the pericardium, and then that causes a fibrotic pericardium with it's really stiff shell, so the heart can't expand as much, and the blood then starts to back up, and you get right heart failure signs like JVD and the edema and the ascites, and the Kussmaul sign. So like instead of falling with inspiration, you breathe, the jugular venous pressure rises because the right pericardium prevents the right ventricular filling. So it should fall with inspiration, but it's paradoxical Kussmaul sign because of that backup. And then on this one, the cholesterol stuff. So what's happening here is you have a catheterization or a vascular procedure that dislodges the cholesterol plaques from the large arteries like the aorta. So it dislodges these guys, and they break into cholesterol crystals, and they travel downstream, and they lodge into the small arteries of where? The kidney. The kidney, the skin, right? And the body reacts with inflammation of eosinophils, and there's a triad, acute kidney injury, and the livedo reticularis, right? Eosinophilia. That's what's happening here. So cardiac, catheter, vascular surgery, thrombolysis, anticoagulation, the kidney is involved, acute kidney injury, the skin is involved, you have blue skin, the modeling, all that stuff. So this is a cholesterol crystal embolism in these vascular procedures. Alrighty, and then during an autopsy, yellow streaks are found in the aorta. What is the predominant cell type? Macrophages. They ingest the lipids and become what's called a foam cell, my friends. And guys, just like that, we made it. Was this helpful? I know I started off the stream kind of slow, but that was just because I was finding all of these images. And I'll slowly be adding to this, but would this be helpful if I make guides like this? And how helpful was this? I'd love to hear your guys' feedback. Let me know on this video or other channels. And I'm making this for you guys. I want to give a lot of these resources just for free. And if you guys like and subscribe, that'd be awesome, just because then I can get monetized and I can keep making more content like this. But I'm going to give this guide out to you guys for free whenever I finish making it. And I've already started working on the 7 others earlier this morning. I was doing that. So thank you guys so much for watching here. And hopefully this live stream hasn't been too kind of finicky, and I'll be purchasing a cable so that we can hang out and watch some more and do some more questions together this weekend. So I'm thinking Saturday morning I should have all this figured out. I hope Friday night. So that's literally today. So maybe tomorrow morning I'm gonna try to get all this stuff like figured out. I'll go to Best Buy in the morning and we can do some practice questions together. How does that sound? Well, everybody, thank you so much for watching, and we'll see you guys in the next stream. You